right, good afternoon, everyone. It's not quite 3 o'clock. We're about a minute to. I don't want to start early, but I did want to hit the record button because we tend to forget that, and that's a problem. If you've missed the last 2 weeks of the webinar, I've been getting emails from folks requesting the links to those recordings. And once I switch this over to Patty later today, I will try to remember to put those in the chat so that you have links to the prior 2 weeks. Maybe we can ask Amy to do that. Patty, I can have her go out and grab those recordings and drop them in the chat. So it is 3 o'clock. I am Jana Broughton from Superior Health Quality Alliance. Good afternoon. And this is the Infection Preventionist Work Group. And joining me today is Patty Leonard. And joining us in just a few minutes will be Amy Wagner when she gets back from an errand. And before we start today with the slide deck, I just want to recap some questions and some confusion that folks have had. You know, we learn with you and we learn from you. And there's a couple things that I want to clarify. The first, last week, there was some discussion around outbreak definition. And in thinking about our response to outbreak, I'd like to clarify that we look at outbreak in like two ways. One, how you respond to an outbreak and how you report the outbreak. And I think that's where the confusion probably lies, and we were confused about the discussion last week. Outbreak response is triggered by a couple of things in a long-term care facility if you are licensed by CMS. CMS is still utilizing a few QSO memos, and that's what you're seeing on your screen. And this is a QSO memo that was revised in May of 2023, and this has not been rescinded yet. It was updated guidance to align with the ending of the PHE. And there are still, if you're new to infection control, and we have some folks who are new to infection control post-pandemic, they've not done this role, they weren't working during the height of the pandemic. CMS has some rules that they have not brought into their formal rule document known as the State Operations Manual, or we affectionately call it the SOM Appendix PP, which is where you find the federal regulations that govern long-term care. So the memos, when they send them out, they become, I don't know, Patty, how to describe it. It's almost like it's a legal rule, right? It's the new
they're the requirements, the regulations for that.
Yeah. So this is a legal requirement from CMS. And I am going to drop this link into the chat when I turn it over to Patty. I've got a bunch of links to copy and paste. But this is the first one. And this is the memo that we use when we talk about an outbreak response being to anything above the normal baseline for an infection. In CMS, in this memo, and it's a weird spot that they put the CMS definition of outbreak, but I highlighted it for you so you can reference it. It's under the indoor visitation. It's an interesting paragraph to have it included, but the outbreak investigation is initiated when a single new case of COVID-19 occurs among residents or staff to determine if others have been exposed. So basically what they're telling us is that we initiate an outbreak investigation, a response to an outbreak in our facility with one COVID positive patient or staff member that we determined happened, contact trace, right? So it initiates the work that you do to respond, to control the illness from spreading, to control the virus from spreading. That's your response. An outbreak reporting is what you report or what triggers you to report to your local health department, your public health authorities, whomever you need to report to based on your state, local governance, that you're having some type of illness or outbreak in your building. For example, with Legionella, if you had a Legionella case test positive in your building, you would want to involve them because it's above that threshold of 1, right? It's above that threshold of 1. COVID and other respiratory illnesses generally are a case of 2 or 3. It depends on your health department. Again, every state, every local municipality may do this a little differently. We encourage you to reach out to your local health department, your local health authorities to find out what that trigger number is for specific illnesses and have that conversation with them and get their source document so that you know what the outbreak reporting recommendations are for your state. So to even further complicate or muddy the waters. So there's a lot of information about this. So this is from Cora, and Cora is, oh gosh, I knew I was going to not remember this, but there's an acronym for response to healthcare acquired infections. And they are the principal at CDC and Cora, they work together, and they just published a bunch of new updates. Their website was updated. In fact, we received the notice today, this morning, that their website was updated. And I'm going to drop this link into the chat for you also, because this has a ton of information about how to respond to outbreaks and what the definition and concepts are of all of the different types of illness outbreaks, investigation, surveillance, et cetera. And it's for all healthcare settings. This is not just specific to nursing homes. So they have, and I highlighted under Chapter 4, Outbreak Detection and Reporting, and this is what they define. An outbreak is defined as the occurrence of more cases of disease than expected in a given area among a specific group of people over a particular period of time. So be that what it is. So that's what an outbreak is defined as. And determining a single definition of outbreak that fits all HAI, AR situations can be challenging. So it often states to have established pathogenic or pathogen-specific reporting thresholds, which I believe your health departments do have pathogen-specific reporting parameters. So that's why it's really important for you to reach out to your local health departments to find out your reporting, not the response, but the reporting. Responding to any type of illness in your building, anything that pops up in your building, you should have a response plan. It should be part of your policy and procedure to respond to, like, for example, a positive COVID resident. That should trigger you to do contact tracing, possibly testing, enhanced testing if you can't contact trace it, and to start your line listing and surveillance. So I think that's, if I have any questions, does anybody have any questions that they want to chime in on this or thoughts about this? Because this is meant to be two-way, and I want to have conversations about it. But I hope that helps clarify the definition or discussion around outbreak a little bit more. And this is a really good source, and we're going to drop this in the chat for you in just a second. The other part that I want to clarify and talk about is OSHA record keeping. When we work with facilities, there's a little bit of confusion around fit testing. And fit testing is a weird one because fit testing, there isn't really a specific F tag requiring you. Like, there's not an F tag around respirator use in nursing homes. It falls under F880, under PPE donning and doffing, the aspects of source control. Record keeping and fit testing really falls under a different federal and state agency, and that's your OSHA's. And OSHA requires that you perform fit testing to a very specific standard, and OSHA has very specific rules around record keeping. And I'm going to share, this is the OSHA requirements, and OSHA does their definitions in these unique things where they respond to letters from people. And so this is a letter that they responded to back in 2013. It was a letter to OSHA, and they responded. And this becomes, when they respond like this and publish it, it becomes their equivalent of a CMS statute. It's like, this is their interpretation of their guidance. And so this is their discussion about employee record keeping. When you have staff and you perform fit testing in your building, if your health personnel, your nurses, you as a nurse practitioner, a PA comes in and provides that fit testing, your policy needs to be very clear about how those records are maintained for that particular staff member. The survey that the staff person fills out, like if I go to get fit tested and Patty's fit testing me, she would hand me a blank assessment that I fill out. It's me filling it out as the patient, as the person being fit tested. I would only share that with the person, the medical person fit testing me, which if Patty was the person fit testing me, I would share that with her. She would go over it with me. And then one of two things, she would either hand it back to me, or if our policy for OSHA follows the OSHA recommendations of record keeping, where we keep the records in a separate and safe office outside of the administrative offices, like we talked about last week, being a separate place, you need to make sure that your record keeping is following the OSHA guidance. And as an infection preventionist, this probably doesn't fall under your purview of requirements, but it's good for you to be aware of that so that you talk to your administrator, your director of nursing, your HR about how you're keeping medical records of your staff. And I just would caution you to read through this with them and to make sure that you're handling those surveys correctly, because that really is employee property and it's employee private healthcare information. So there's two parts to that. And this is the actual guidance. It's on section 22 and 21. And it talks about the medical evaluation form. And that's the form that I'm talking about. You cannot pre-fill those medical evaluation forms. You can't even put the staff's name on it. It has to be them themselves that fill the form out. And that's here in the statute. And they need to complete it and have that discussion with the medical personnel who's completing the fit testing. And when they're cleared for fit testing, what you should be getting and what you should be keeping is the fit test that they are, the type of N95 that they were cleared to use or that they successfully passed. So if mine was a 3M style fit test, you would put the 3M style N95 respirator on my form and say, Jana passed this on this date, and that's what's maintained. Hope that's a little clearer. And I'm going to put this in the chat for you all to review. It gets into a lot of conversations, but I think it's good to have those conversations because I know Patty and I have had these conversations. We both worked in long-term care, especially during the height of the pandemic. And, you know, I know that those forms were kept in infection preventionist offices. They were kept in the DON offices because we were doing them on the fly. Sometimes they'd be on a clipboard. We know that what we were doing was not the proper way to do it. And as we've gotten more finessed and more, you know, successful and we've got more experience about this fit testing thing and what it is, we recognize that there's more to it than just teaching somebody how to wear an N95. That help, Patty? Do you think that clarifies it?
I think so.
I have something in the Q&A. Does anyone have an N95 fit testing and medical clearance policy for nursing homes that they're willing to share? We don't, Alicia. However, I will share with you, I don't know if your facility is a member of American Healthcare Association. I do know that ACA has, and they're offering to members and non-members for a fee, a fit testing kit. And it is an entire encompassing education, policies, procedures, videos, training, and even the hood and supplies. And it's fairly affordable. Like they've really brought the price of it significantly down. So that can be found out on the American Healthcare Association's website. You might want to go out and ask your state associations if it's leading age, you know, the county medical care about their ability to help you with policies and processes. But that's something that you might want to consider. So I hope that helps. All right. So with that, Patty, I am going to quit sharing and go ahead and you can, I will stop sharing and you can share and I'll drop these in the chat for everybody.
All right. All right, do you have the screen now?
Yes, I can see it.
All right. So this is week 3, everybody. We're going to lighten it up a little bit here. So today we're going to talk a little bit about bloodborne pathogens. We're going to talk about injection safety, and the bulk of the slides are on environmental cleaning and disinfection. So just a quick review of the bloodborne pathogen policy. Do you have time to put a quiz up, Jana?
Yes, I will go ahead and do that right now.
Okay, here's the question. The bloodborne pathogen plan is a regulatory requirement by which of the following regulatory bodies? Your state health department, Board of Nursing, CMS, OSHA, or CDC?
We are seeing occupational, OSHA.
Yeah, and that is the correct answer. It is another requirement of OSHA. So what are the requirements for a bloodborne pathogen, or the other term for it is exposure plan? And if you look at the bottom, I have a lot of resources there, but it is required for all health departments that you have a plan. And this plan has to include how the facility will handle sharps, what you're going to do if someone is exposed to blood or body fluid. So a nurse gets a needle stick. There has to be information available. They should have training on what to do. And I always ask the question, does your night shift nurse know what to do? Does your weekend supervisor know what to do? What about your maintenance man? A lot of facilities will have a binder somewhere that they have the approval forms, the incident reports all contained in there, but your staff needs to know what to do. And if you have a requirement that they notify the DON, the infection preventionist, the nursing home administrator, all of your staff should know that as well so that they know what to do. Need to have procedures for cleaning, hazardous waste disposal, how to handle dirty laundry, contaminated laundry, as well as offering your staff hepatitis vaccines. I'm hoping everybody knows that that's a requirement. Most likely your HR is handling it, but it is covered under this OSHA regulation. We already talked about the plan being accessible to staff. Staff education, it is required on hire and annually. Now, if you're using a Relias or Healthcare Academy, most likely it's contained in that material, but I would recommend that you include the specifics of for your facility, like we talked about, who do they have to notify? Where do they go if they need treatment? And that the supervisors know what to do. And that you have those eye wash stations available, that you have any type of first aid equipment, that all the steps should be available. And then the record keeping of the training is also a requirement, as well as logging of any kind of exposure or any kind of injury related to work. And usually, like I said, the human resources people will handle that for you. Your injection safety, and this is all, again, part of standard precautions that we talked a little bit about last week. And the guidelines are there in the bullet points that injections should be prepared aseptically in dedicated clean areas. And a syringe should be only used to administer medication to one patient, should never be reused to access the medication container again after it's been used for a patient. And those single dose vials, they should only be used one time. There's no preservatives in there, and they should only be used for one patient. And CDC has a campaign. It's called One Needle, One Syringe, Only One Time. They have great little posters you can hang up. This is an injection safety checklist. You could use it for an in-service. You could use it for a QA, but really good material there. And then your point of care testing. So that would be for your blood glucose tests. Remember to use the single use, the retractable finger sticks devices. And this again should be done using proper technique. The nurse should wash her hands, put on gloves, use the alcohol prep pad. And this next one I put on there, do not carry extra supplies in your pocket. I'm an old nurse and I was a pocket packer, as I would call it. Anything you might need, I wanted in my pockets in case I needed it more. It's not best practice. And as Janet talked about, I've learned a lot since I took this position. And I was doing things that weren't right. Best practice would be to carry in the material, the supplies that you need on a little tray. You can, buy those little styrofoam trays. You can make them from whatever, but just have a clean surface for your material. And your meters, if you're sharing them, need to make sure that these are healthcare meters and that you're cleaning them according to the manufacturer's instructions. And if there's no instructions on how to clean and disinfect between use, then you shouldn't be using them that way. But even if the residents have their own meters, they still need to be cleaned and disinfected. And we have a list here of approved cleaning agents for you to look at in case you want to check and make sure that your product's appropriate and that will kill the viruses, the HIV, the hepatitis viruses. Here's a great little pictorial clinical reminder, it's called, from CDC. Again, a really nice tool that you could use for an in-service or an education. And it's sourced at the bottom. Insulin pens. Most facilities are using insulin pens now, which definitely has made it a lot easier for us nurses to get the appropriate dose administered. These are still only for one resident. They should be labeled when you get them from pharmacy with the resident's name. You can't, there's no exceptions for this. So it's one insulin pen for only one person. And they have great little posters and little campaigns for that as well from CDC. Needle sharp disposal containers. Most med carts have them. Some resident rooms have them as well, but If you're giving a lot of immunizations, like going around giving flu shots, or you're giving insulin and there is not one at the bedside, I would get one of these small ones that you could carry, and that way you could dispose of your needle correctly at the bedside. And they're available through any medical supplier. You can buy them Rite Aid, wherever. A quick push for staff education starts with orientation. And I do want to caution, when you're hiring new nurses, we can't assume anymore that they've had experience with and knowing how to give injections, let alone starting IVs. They probably don't even know how to do a blood glucose test. So we need to go right back to basics with them. You're going to have to teach them and then do competencies on them so that you know that they have that skill set and that they are safe for the residents and themselves. And then you're going to continue to have to do an annual competency validations. And as always, with infection control, we recommend audits that they're following all the correct procedures for injection safety and for blood glucose testing, as well as disposal of their syringes. So more resources for you to use if you need them. We also have other ones available. I actually even put a comment up there, very good, under a little video up there, safe injection practices. And Jana, it's all yours for environmental services.
Thanks, Patty.
That was
quick.
quick.
To talk about house cleaning, my least favorite subject when it comes to my own personal house. All right, so quiz number 2. I'm going to drop a quiz here. I'll put a quiz up for you. And so this is a poll. When disinfecting contaminated surfaces, which of the following are important considerations in preventing the transmission of infectious agents within your building? And we are getting responses, and it is correct. All of the above. I probably went too quickly on that, but I think everybody knows this one. This is a good topic, so thank you for that. The Facility Assessment and Environmental Services IPC. So here's some links for you. A complete facility infection risk assessment is an annual assessment that should be done as part of your facility assessment. And this is where it's a little confusing. Again, I always get the confusing topics, ladies. I don't know, the ones that are a little confusing, but your facility assessment, which you probably have heard some about, you might have been involved in your facility assessment because some changes came out this year with that. And a big part of that was the staffing portion of the facility assessment. Among other things, they've really added a lot to the assessment. But something that people maybe didn't necessarily realize is that an annual infection control risk assessment needs to be done. And that basically, we gave you the links here to the CDC ICAR for general IPC, and then in the DHS Infection Prevention Starter Kit, there's some modules there for you to look at and consider. But your infection risk assessment basically looks at the risks of your facility in conjunction to its location, where it's at, what's going on out in your community, what's going on around you, infection rates, et cetera. And this will walk you through a lot of that. So if you ever have questions about your risk assessment, or you'd like to walk through it with one of us, please feel free to reach out, and we're happy to do that. All right, Patty.
Some technical difficulties now. There we go.
Oh, there you go. So under F880, it states the facility must establish and maintain infection control program, and that it must be based on the facility assessment and acceptable national standards, and your infection control program needs to be reviewed annually. And we call that the Infection Control Assessment and Review. It's called an ICAR. And you can find the ICAR right on the CDC website. It is fillable, and it will trigger you to ask for documents or to look for documents, and you can do it section by section. And here are those national standard resources for you to look at when you're looking at and completing your risk assessment. And there's just a lot of additional information here for you. And those are the acceptable resources according to CMS. So the goal of the Environmental Services Infection Control Program is to break that chain of infection. It's to stop the infectious agent from entering a susceptible host. And you do that through physical barriers. How do you do that? So it's cleaning and disinfecting the environment. You're breaking that chain of infection. You use the correct product on the correct surface with the correct contact time. And it helps. The other part of this is keeping ourselves from spreading the infection by good hand hygiene, performing safely while performing tasks. And remember that we need to include pest control, animals, and waste management in a good environmental services program. So those are sometimes things that we forget about. And I love, this was Jessica's slide deck and she's out with us, but I love that she used this chain because it is like the chain, right? It's the core components of environmental cleaning and disinfection. And it talks about these are the things that you need to make sure that you're doing. You need to have good products. You need to make sure your products are appropriate for what they're being used for, that you have standardized protocols, standardized ways of cleaning, and that you have good policies about those cleaning, and that you're monitoring adherence to all of this. And with environmental services, the second circle, the education and train, we're going to talk a little bit more about as we go on. So how do we interrupt the chain of infection? So this is a good visual that we have to kind of give this to, you could use this for your staff. So you talk about a colonized or infected patient and they touch something like they cough, or let's say they're eating on their eating utensils, or they spill something on their tray, or they're touching their over the bed table. And that's a contaminated surface. So we now have a contaminated surface. If I go in and I touch their table, and those are my healthcare personnel hands, right? And I don't go and do hand hygiene, I then can take my contaminated hands to a susceptible patient, and they now become that colonized or infected patient. I like to use the visual of norovirus because I think that's a really easy spread virus. We're going into that season. We just talked about kids bringing lovely things home to us. And that is something that probably everybody on this call has had experience or exposure to, unfortunately. And, you know, that's that chain of infection. All right, so this brings us to quiz number 3. And I'm going to get that popped up here. So when cleaning soiled and contaminated surfaces, which of the following is the best practice to follow to prevent further spread of pathogens in the environment? And it looks like our folks know the way to clean. Well, maybe. So actually, we get a little confusion about this one. I think it's okay, and I'm not going to put the numbers up here. The correct answer is D. It's cleanest to dirtiest, highest to lowest, with the bathroom last. Now, I will share with you, until I worked in long-term care and became familiar with infection control practices, I was the person that always cleaned their bathroom first because I always thought, oh, I want to get it over with. It's the dirtiest. I got to get it done. But what I probably was doing was spreading those lovely germs everywhere else in my house because I would use, you use your Lysol rag. So the response is clean to dirty, high to low, bathroom last. So here's a good graph where we talk about the difference between cleaning, sanitizing, and disinfecting. And this is something, again, that really came to the forefront during COVID. We talk about cleaning. I'm not going to go through and read these to you, but this is a good tool for you to use when you're educating staff and for yourself as a reminder about what's cleaning, what is sanitizing, and what is disinfecting. Cleaning is the stuff that we do daily. Like I was sharing before we started, I baked cookies, or I made cookie dough this afternoon before my lunch hour so that I could take it to the grandkids. I cleaned my kitchen. I didn't disinfect my kitchen. Disinfecting would be me going upstairs using an EPA registered disinfectant, letting it sit on the contact time, letting it kill all the germs on those surfaces. So, those are the differences between when you look at it. So think about in your own home and then how you can make it. I like to use personal examples when I'm training staff so that it brings it home for them so they can think about it in terms that are familiar to them. So, all right, next slide, please. Product selection. You need to make sure that the products that you're using are EPA approved. This is a live link to the EPA registered disinfectants by organism, which I think is a really good way to look at your disinfectants. If you get an organism in your building, you need to make sure that what you're using to sanitize and disinfect in your building will kill the organism. A good example, again, going back to norovirus. A norovirus is one of those weird microorganisms. Correct me if I'm wrong, I don't want to misspeak, Patty, but bleach is what we traditionally would use to kill norovirus. Is that correct? It was bleach wipes. because it was susceptible to chlorinated bleach. But use this list because there are multitudes of disinfectants that you can use and some that are not recommended for that particular
Well,
organism.
and a lot of disinfectants, want to claim that they will kill everything, but you do have to read all that small print there.
Yes, the length of time,
Yeah.
like contact time is really important. And make sure that you also follow the manufacturer's instructions for use. For example, going back to the glucometer cleaning, when you're cleaning glucometers, make sure that you've read your manufacturer's instructions on what they recommend to clean it with, because that glucometer needs to be cleaned in between use, and you need to really pay attention to that if you're sharing glucometers for residents. So surface types, contact time, labeling, and then safety precautions are all things to pay attention to. So your EVS cart and equipment. These are some things that we need to think about when we're looking at the EVS cart. How many of you have actually gone out and looked at your housekeeping trolleys that your housekeepers are pushing down the hall? A lot of our housekeepers are fabulous, amazing, they're fabulous, amazing people. They do crazy good work, and we fail to give them a lot of credit. But one of the things that we also fail to do is provide them with education and resources to understand the purpose of their work. And an example of that is, how many of you have housekeepers that sometimes treat their cart like a personal desk? Meaning they may have their coffee on the cart, they may have things that are personal, like their purse on the cart, their hand lotion out and exposed right next to their dirty mop handle or their toilet brush. So really pay attention to how those carts look, and then dig into and think about who's ordering your supplies, how they're stocking those supplies, and then look at those carts. Are they keeping the clean items separate from the dirty? Are the chemicals locked when not in use? And is that cart free of personal items and drinks? And are we reprocessing mops and cleaning cloths appropriately if we are? And I think on the next slide, Patty, when we talk about, there's that cleaning of rooms, when we talk about clean to dirty, high to low, clockwise or counterclockwise, isolation rooms after other rooms. So your COVID rooms or isolation rooms, enhanced barrier precaution rooms should be cleaned after the other rooms are cleaned. And the best practice is to use those microfiber cloths and mop heads and to avoid double dipping. So what do we mean by that? It means a one and done. So if I use a rag and I go and I clean, I'm cleaning the high surfaces in a room and it becomes, do the quad fold, I should throw that in a bag and get a clean rag to go on and do the next portion. So don't dip back into it. Once the rag becomes dirty or dry, we throw it in a bag to get washed and we get another rag out to use. And then privacy curtains need to be cleaned. I can't tell you how many 2567s that we read that have people are getting tagged under F880 for environmental services, and they talk about cubicle curtains or privacy curtains that are soiled, and they give examples in very specific graphic detail about what was on the cubicle curtain. So cleaning bathrooms, clean it last. Make sure that you have the supplies are stocked. We empty the trash, right? That's the cleanest thing probably in the bathroom, is to empty that trash. Then we clean the sink or the tub. So you think about the sink as probably the next least dirty thing in your bathroom. The walls, walls around the toilet, and then the toilet itself, and then you mop the room and do the floor. And then you should be done with your room. So here's a surveillance audit. Go out and do that observation of your housekeepers to see how they're cleaning the rooms. Are they doing top down? Can they walk you through what they're supposed to be doing? And then not only can they verbalize it, but are they physically doing it in the order that it should be done? Have they ever been educated? So planning for day-to-day operations and emergencies, it's important that, just like any other department, that environmental services has a backup schedule. They know what to do in case of staffing gaps. And do they have a process if they're understaffed? Do they have checklists and logs and things that are prioritized based on staffing? And what about a process for an emergency? Do they know how to respond to that? What about reporting accidents, incidents, concerns, or safety issues? And then what are we doing for employee health, immunizations, and illness recognition with environmental services? I would encourage you all to take some of these slides back to your environmental services staff and kind of just sit down with your environmental services director and go over go over the slides. And I see we have a couple questions in the chat. So Amy, I don't know if you want to go out and snag those and interrupt me if there's anything on there that we need to stop and discuss.
There is a question that says, do we want to clean rooms for enhanced barrier precautions last if that resident does not have an MDRO, but is at risk due to open wounds, IV lines, etc.?
So that's a great question. So nurses, what do you think? Is it a higher risk or a lower risk to clean it last? With
Wow.
open wounds or lines? Yeah, it's a great question. Yeah.
You know, let's do some research and we'll bring that. We'll see. We'll poll some of our other experts and we can bring that back next week.
Yeah, we'll take that back to the group because I see the point on that. I would have apprehension about it. Hypothetically, they should have their own mop and cleaning supplies, right? It should be cleaned, but you're going to want to make sure you're not bringing any organisms to that room so that you don't spread an MDRO. I completely understand that discussion point. So great. You guys are like stumping us this whole go around on Infinity, which I love because that tells me that we're really thinking about things and really figuring it out and trying to figure it out for the best of our residents, which is why we're all here. That's awesome. Yeah. All right. Surveillance tools and resources. Here's some resources for you on environmental services. We did put together an environmental services cleaning video series. And I don't know, do we have that link? I suppose we can get that link and put it in the chat. But it's a link of their videos that were done with Dr. Buffy from IPC Well and then a post test. So it really is an opportunity for your staff to get some additional education. And it's specific to housekeeping staff and laundry staff, which is, it's really good education for them that you could use for possible annual review of education. All right, cleaning of shared equipment and high-touch surfaces. So considering all the items that fall into this category and who is responsible to clean, make sure that you have skills training, competency testing for those responsible. The items are cleaned between each resident when visibly soiled and keep disinfectant easily accessible. So what would that be a good example of? And they give you some examples in this picture, which I love. Scopes, your vitals machines. So a lot of you use the vitals machines with the basket for the blood pressure cuff. How are we cleaning that in between use? Have you checked your staff to make sure they're competent, they understand how to clean it? How many of you have gone to your physician's office and watched them put, bring a blood pressure cuff out to you and you've ever wondered, have they cleaned that thing before they put it on my arm? When was the last time that stethoscope was cleaned? Yeah.
I think my comment to this is sometimes you have to get really, really specific and identify what I say is who's going to clean what when. Otherwise, sometimes there's a lot of finger pointing and people that feel that certain things to clean are not their responsibility.
Yes, I agree. Like oxygen concentrators come to mind. They get shoved in a dirty utility and nobody cleans them.
IV pumps, suction
machines.
Yeah.
Yes. All right. Mattresses and pillows. You need to make sure that you're looking at these items to make sure that they're free from holes because holes and tears can allow urine and body fluids to get down into them and just, cause it to become contaminated. Tears and excessive wear, and you need to disinfect them between residents and per schedule. The same with pillows, and then discard both if penetrated by body fluids, and then a system to monitor and identify when they need to be replaced. I know most facilities do a dating system on mattresses, pillows, like your mechanical lift slings probably have dates on the tags of when they went into service. A lot of your cubicle curtains will be dated. And those are a good practice just to know and keep track of when things are going into service so that you can kind of get a rotation to make sure that you're pulling the older items and putting new items into service.
I would also like to add onto this wheelchairs.
Oh, good question.
Yes. Thinking about, the cracks in the seats, the cracks in the armrests, those
rust on the wheels.
Yep.
Yes.
Anything like that that's got a pillow or a support surface, how often, what's your cleaning practice for those?
Wheelchair cushions.
Yes, they can get really, really
cushions?
nasty.
And then here are some resources. There's an audit tool that we've created for your mechanical lifts that you could use to do surveillance and auditing on your lifts. And then the cleaning and disinfecting, kind of a best practice tool. And then APIC reports a study of 30 surfaces in 11 facilities. 92.3% were found to have a high level of fecal matter. And of course, handrails and equipment controls were 4 times more likely to have high levels of contamination. So when you think about your handrails and your equipment controls, so those controls that you use for the bed, the controls that are used for your mechanical lift, high levels of contamination. I think if you're going to share one slide with your staff to get them to promote cleaning, this statement right here would be a good one to share with your staff. Just 92.3%.
Yeah,
So,
you just kind of get the wellies thinking about that. So
yes, I would share it right before lunch. All right. So here's some examples of high touch surfaces for your resident rooms. I'm not going to go through these. You guys could add to this list. And you know, what others can you think of that are high touch just in your head? Like what else is out there for high touch surfaces in your building? And it might be a good question to do with an all staff. Like, okay, so when you're doing education, like what other surfaces can you think of that are high touch?
yeah,
So,
telephones, think about the keypad where everybody punches in the morning, or the laptops that the nurses are using for med administration.
yes. All right. And that was the last tool.
Yeah.
We'll just give those to them. All right. Laundry management. Am I still going, Patty? Or is
Yep,
this
go.
you? Nope. Okay.
Go ahead.
So for those of you that don't know, that Patty and I are switching back and forth today. So it's all good. All right. Which of the following would be the correct way to handle soiled laundry in long-term care facility based on current regulations? And let me see. I am not getting this to, oh, there we go. I'm sorry. All right. Technical difficulties. Which of the following would be the correct way to handle soiled laundry? Based on current regulations.
That was fast.
That was very fast. So treat all laundry as contaminated using gown and gloves.
Absolutely.
You know, we can all say that, right? And I'm going to share with you though, I can't tell you how many 2567s we read that staff are not wearing gown and glove when they're observed by a surveyor. And just again, it's another observation for you guys to work with your staff and do some education. So laundry services, you know, sometimes they're tucked back in the back of your building and we don't think about what they're doing. We don't go back and critically look at laundry. So these are some of their responsibilities on the cleaning of bed and bath linens, to make sure that they're transporting and processing laundry to prevent the spread of infection, meaning it's covered when it's coming out clean, that they're handling clean resident laundry appropriately. And when they're sorting laundry back in the laundry room, like the dirty and clean is kept separate, the door is kept closed on your dirty utility before it's brought in. They're not fluffing, I don't know how to describe this, fluffing dirty laundry, when they're not shaking out dirty laundry when they're shoving it in the washing machine close to or next to their folding table, actual 2567 that we've read, and that their fans and equipment is in good repair and not dirty back in the laundry. So just put your critical eye on this one, something to consider doing some surveillance, and that it's got a regular cleaning schedule that your staff understand, and you know, they're giving thought to making sure their laundry space is clean and appropriately cleaned. So again, handling that laundry, we just talked about that minimal agitation to avoid contaminating surfaces, air, and the air and people. And sorting and rinsing is completed away from resident areas. I think that also is very, very important. Transporting laundry, hold contaminated laundry in bags away from the body. Special precautions are not necessary. I think what she meant by this is that in COVID, like we're not using a red bag for COVID. I think that's what Jess meant by that. But we should double bag visible contamination or leaking. If you have something that's incredibly saturated and it's dripping, you should double bag that just so that when it does go back to laundry, it's not contaminating everything and a laundry person, isn't getting their gown soaking wet from the
Your
leakage.
cart getting all nasty.
And your cart getting all nasty,
Yeah.
yes. And then clean and disinfecting the carts when visibly soiled and per schedule. And that separate carts are used for clean and dirty laundry, or they're sanitized between use. And protecting and covering clean laundry from debris when transported. It's very important. Covers are not required for contaminated receptacles in resident care areas, but may be preferred or required by state law. So check with your state. And clean and contaminated laundry must always remain separate. It needs to be separate rooms, separate closets, designated spaces with a closing door, and closed when not in use. And it should not be easily accessible to residents or visitors.
This tips for meeting linen requirements down here is a really, really helpful. It'd be great for an in-service.
Just like in dining, your laundry processing has specific requirements for your detergents, your additives, and your equipment. When surveyors do come in and do infection control rounds, they will go to your laundry, they will look at your laundry, they will pull your lint traps, they'll look under your dryers, they'll look behind your dryers, they will check temperatures, and they'll check your flow of your chemicals. And if you have automatic dispensers into your machines, somebody in laundry maintenance, someone needs to be able to speak to how that works and who processes it and how it's verified. Laundry chutes need to be minimize aerosols, so no loose items are closed, and you need to use closed bags. PPE and hand hygiene supplies need to be available and be used, and workflow should prevent cross-contamination of clean laundry. And fans do not allow air from soiled area to enter the clean area. So if they're using fans, you need to make sure the direction of them is correct. And here are some surveillance tools and resources for laundry management. Any questions about laundry? I guess probably not. All right, so we're going to go through QAPI pretty quick. We got a lot of slides to cover. This is a topic that's near and dear to my heart. So Patty and Amy just cut me off if I get rambling. So
Okay, you got about 13, 12 minutes.
I see that. All right. So this is important information for you guys to understand, though. You have a critical role in QAPI. Your role is really to bring to the QAPI committee all of the outcomes of surveillance and to advise the committee of areas of concern. You participate in QAPI as an active participant to promote quality and decrease risk in high-risk areas. You're the expert of infection control coming to that team to inform your team when there's updates in infection prevention practices. And then you act as a resource in any infection prevention discussions. So here's some references for you to use when it comes to like QAPI. I'm not going to go through each of these individually, but they're good resources for you to consider and to think about for QAPI. And then here's some CDC references also.
Okay,
And then
I guess we were closer to the end than I thought.
yeah, I'm like, wow, you were speeding me along there, Patty.
Yeah.
So go back to QAPI for a second. I want to go back to QAPI because I think I talk about this in week 6 also.
I'm going to stop sharing and grab that link for those slides.
Absolutely. When we talk about QAPI, we've gone through a lot of information about surveillance, and today we talked about environmental services and infection prevention around surveillance of laundry and housekeeping, and cleaning of shared equipment. So all of those things that are cleaning related. If you are struggling as a facility to come up with ideas or ways to do surveillance, I would encourage you to partner and become really good, develop a really good rapport with your environmental services, the person who manages your housekeeping and laundry departments, or people who manage those departments. Those two departments have critical points in breaking that chain of infection and can really be your best ally. We created, Superior Health created this series for the infection preventionists related to, we put that series together for the environmental services because we recognize that they often don't get very specific education designed just for them. They're included in nursing education or all staff education. So the series, the environmental services series, is a series that we created specifically for housekeeping and laundry, and it walks them through best practices for cleaning and with actual videos demonstrating best practices and different aspects of it with post tests. that you can utilize for competency to do, like, is that first part of education and then going out and actually validating on the education. And then Patty just dropped into the chat the Superior Health, the link for those Safe Clean series.
Safe Clean series, yes.
The Safe Clean series.
So Janet, can I
So-
just make a comment? So
Sure.
somebody had stated that they received a message, the chat was disabled. So if anybody is getting that message, put it in the chat for us and we'll take a look at it.
Yeah, chat's disabled under this format. You have to use Q&A. Don't ask me why, but with Zoom with this format, we are chat disabled for everybody, but the panelist should not be disabled. That's interesting. So, but it's Q&A. So Amy, if it's not functioning for you, I did drop the slides in there for today. So you should have the slides for today. Is there any questions that anybody has around cleaning of shared equipment, environmental services, or laundry? We covered things pretty quickly. We will come back to you with a response about enhanced barrier precautions. I would love to hear from you on how you're handling enhanced barrier precautions and what you're doing from an education standpoint with your staff on the cleaning mechanisms of enhanced barrier precautions. Like, what are you seeing? What are your struggles with enhanced barrier precautions? We have a few minutes, and I know that was some feedback we received last week that you would like more information on enhanced barrier, and we can talk about it every week if we need to. So if there's any questions that anybody has about enhanced barrier or specific scenarios that they want to run by us, please bring it to us. We will, if we can't answer it, we will take it to others. For enhanced barrier, do you need do we need C trash cans? Do we need individualized trash cans? I'm assuming is the question. So for enhanced barrier precautions, you should have trash cans that have lids. That is the best practice, and it needs to be a trash can. Correct me, Amy, Patty. Go ahead, Amy. You want to answer it, so go for it. Oh, you're muted.
I'm sorry. What was that? I'm sorry. What did you say?
So the question was, for enhanced barrier precautions, what about trash cans? What do we do with trash cans?
Are we using the biohazard bags in these trash cans?
No, just for enhanced barrier precautions. She
Oh,
wants to
enhanced
know if we need to. So yes, you need an individual trash can for enhanced barrier in the resident room, correct?
Correct.
And it should have a lid. Best practices, you should
Yep.
always have a lid on your
Yeah,
trash cans.
That's, so you take off the PPE as you're leaving the room.
That is the best practice, and it should be separate. It should not be a shared trash can in the room. Yeah, specific to the resident that's on enhanced barrier precautions.
It should be empty routine. They take it out as your immediate disposal.
Yeah. Okay. All right. Any other questions on enhanced barrier precautions anybody has? Patty, Amy, anything else you want to add to today?
Okay, next week we have antibiotic stewardship. We'll talk about McGear's and Loeb's criteria, antibiograms. So think about those questions that you might have along those topics.
Yes, and if anybody has anything else that they would like us to talk about in the next 3 weeks or cover, we can do that. We are, again, if there's resources that you need or additional resources that you would like, please let us know, and we will get those out for you. I am going to drop the feedback,
Oh, you need the evaluation?
the evaluation.
Oh, hang on here. I got to share again to take us to the last slide too.
Yes. Survey. We will cover coffee more in depth. I think it's week 5 that we'll go to QAPI. And we will also do a walk around the Superior Health website in week 6, which will be new for me too, because it's a new website. And finding items. So go ahead, Patty.
Yep.
We want to make sure we get this last slide in so that we have it for you.
There we go.
All right, and there is the statement of work slide. So with that, thank you all for your patience today, and thank you for letting us have that conversation at the beginning. To clarify, again, if there's ever any confusion or clarification on something that we've stated, or you would like more information on, please do not hesitate to reach out. I did not get the link to those recordings, so I need to get those. If you want to hang on, if you need those recordings from week 1 and week 2, if you hold tight, I will go and grab those recordings really quick.